All right, I think it's time. Hello everyone. Thank you for joining another BERD seminar for this semester. Today we have two popular speakers uh, in BERD seminar. Before we start, I wanted to remind everyone that the sessions are recorded. And when you enter the room, you will be muted, but you can, the speakers have let me know that you can, if you have questions, feel free to unmute yourself and ask the questions during the presentation. Towards the after the seminar, we will email you the slides as well as the link to the recording with a feedback survey for the registered participants. Sorry. Today we have, as I said, two speakers. One is Dr. Kyle Kapko, who is the Executive Director of the Center for Rural PA. And then we also have Dr. Lisa Davis, who is an Outreach Associate Professor of Health Policy and Administration at Penn State. She also serves as the Director of Pennsylvania Office of Rural Health. So without further ado, I'll let Kyle take over and talk about interesting stuff. Kyle?
All right, thank you very much. So let me see if I can get the screen up here. And it's very generous to say that I'm a popular speaker. That might be Lisa, but I don't know about me, but that's all right. I appreciate the generosity.
Oh, people have appreciated the presentations before.
So is the slide deck coming through on your end?
Yes, I can
All
see.
right, great, great. And Lisa and I are delighted to be here again. And we have some updated information to share about demographic changes. And we really wanted to focus on, the silver tsunami. We are becoming older. There are fewer young people in Pennsylvania, and that's having a wide range of implications for healthcare systems, also the workforce. We're getting into some new things that we haven't really discussed in previous presentations. But as always, I'd like to repeat some of the basic information for viewers who might not have had the chance to interact with the Center for Rural Pennsylvania before, and particularly since this is a BERD seminar and many folks are likely affiliated with Penn State or other state universities in the Commonwealth. I always like to provide a little background on the Center for Rural Pennsylvania. As you can see here, we are an entity of the Pennsylvania General Assembly. We're essentially a think tank that serves both the House and the Senate in a bipartisan manner. And we have a few mandated action items that we must undertake per our enabling legislation. And one is to administer a grants program for any faculty at our state universities. So Penn State faculty members, if you have an interest in applied policy research, we have an RFP out right now for our grants program, and we're always interested in new topics, particularly whenever it comes to healthcare. So if you or even graduate students or other colleagues have an interest in doing research that could influence the General Assembly, please get in touch with us. We also have a database on all different types of indicators across the Commonwealth. We'll be using a lot of the data from that database here in today's presentation. And then we also have the ability to host legislative seminars, just like a standing committee would in the General Assembly. And one of the interesting things that has since come up within the last year, which grew out of our population forecast developed in partnership with Penn State, is the new Pennsylvania Rural Population Revitalization Commission. And Lisa Davis serves on this commission with me and 13 other commissioners from all across the Commonwealth. Really, the entire purpose of this new entity, and I can discuss this a little bit later on, is to help combat the negative effects of population loss, particularly in our rural communities. The commission members come from state government, local governments, and the private sector. So it's really a good mix of folks with different types of professional experience and background. And obviously, healthcare is at the very, very top of the list in terms of priorities that we should be addressing to ensure that we have a stable population base. And we have the ability to recommend new legislation, regulatory change, and even community best practices as members of the commission. So stay tuned for more information on that. And just for background, for folks that haven't seen our definition of rural Pennsylvania before, we have three definitions, one for counties, one for school districts, and one for municipalities. And it's based on population density for the most part. And you can see here the county definition and the county map of Pennsylvania. 48 of our 67 counties are considered rural. So about 75% of Pennsylvania's landmass, and those 3.4 million people as of the 2020 census, that's a population greater than 21 states and the District of Columbia. So we're talking about a lot of people, a lot of activity. And by the Census Bureau's definition of rural, Pennsylvania actually has the third largest rural population in the country, behind Texas and North Carolina. All right, now some of you have probably seen me present on this before about the aging of Pennsylvania's population, but we're going to present a little more detailed analysis than maybe what you've seen before here. Here we break this out by generational cohorts as defined by Pew Research. And you can see we have the silent generation, baby boomers, Gen X, millennials, Gen Z. A lot of folks, I think, are referring to the current generation as Alpha, but we haven't had that formal designation yet by Pew. But you can see here in both urban areas in the silver, rural areas here in the green, baby boomers are comprising a fairly large segment of the population. But then as we get into our younger age cohorts, we have a drop in population. So thus the silver tsunami. We have this larger wave of older Pennsylvanians on the horizon. And what you can see here is that our average age, both in rural and urban areas, has steadily increased over time. We're about 40 and a half years of age on average as of the 2020 census in urban. In rural, it's about 2 years older. So this has been increasing steadily in the past few decades. And some of you have maybe seen this graphic before, where we are nearing the point where we are soon going to have more senior citizens in Pennsylvania than what we do young people. So senior citizens 65 years of age or older versus those under 20 years of age. And this is what it looked like as of the 2020 census, just to put a finer point on it. This is the current state of affairs right now in Pennsylvania. Any of the shaded counties have more senior citizens than individuals under 20. We have a declining birth rate too, which is reflected in our natural population change. You can see here, this is our 2020 to 2023 deaths versus births net count. So any of the shaded counties in Pennsylvania over this 3-year time frame had more deaths than births, and any of the white shaded counties, which are all in the southeast here, had more natural population change to the positive, so more births than deaths. But overall for the Commonwealth during this period of time, based upon Department of Health data, our natural population change was net negative. So we had a decrease of 75,000 individuals because more deaths than births. And here, this isn't just something that's occurred in the post-pandemic era. You can see here the statewide totals. The number of deaths has been creeping up steadily, the number of births declining. These lines were on a pathway of convergence for a number of years. And if we break this out by our urban and rural definitions, you can see rural lines down here, urban lines up here. In urban Pennsylvania, those urban counties, during the pandemic eras, whenever we really had the death rate surpass the birth rate, and now they're basically the same based on 2023 data. But in rural Pennsylvania, dating back since 2009, the death rate has pretty consistently outpaced our birth rates. And we have updated fertility rates to share since the last time we were here, going through 2023. Now, based on that data, only 2 counties in all of Pennsylvania hit that 2.1 threshold needed for natural population replacement rates. Generally, 2.1 births per woman is needed to maintain a flat population growth over time. That's only happening in Mifflin and Juniata counties. Everyone asks me, Kyle, what's happening in Mifflin and Juniata counties? So you can take a guess what's happening there. Our best guess really is that it's old order and Anabaptist groups that have larger families in those counties, and in a smaller, less densely populated area, that can really make a big difference in terms of the overall averages that get computed. But if you look across the entire United States, we have data from 2018 through 22. We don't have 23 at a national level, but you can see here, the top 5 states, none of them hit that 2.1 rate. South Dakota comes close, but still short of that. Nebraska, North Dakota, Utah, Alaska, still below that. Pennsylvania's fertility rate overall, 38th in the country. So in terms of natural population change, we're not really growing in that regard. Any population growth that's going to happen in the short run is going to be because of people moving into the Commonwealth, both our rural and urban areas. Now, this all really affects the ecosystem in which healthcare institutions operate. And in the next few slides, we're going to give you a lay of the land on where things are right now, and also show where there's some pretty significant gaps in coverage. And unfortunately, as our demographic changes persist, unless if there's new strategies or policy interventions that are implemented in the future, my big concern is that this is only going to get worse. And my colleague, Dr. Laura Domino, presented some of this information with Lisa Davis last week at a Senate Policy Committee meeting in Canonsburg. And what this map here shows is the location of general acute care hospitals as of 2024. So you can see here the stars represent the critical access hospitals, the crosses, the short-term general acute care hospitals. Then we also shade it by our rural and urban areas, and anything that doesn't have a crisscross, or does have a crisscross, I should say, like Pike County here, they do not have an acute care hospital. Based upon the raw numbers, rural has 62 hospitals. In urban counties, there are 86. So that's our landscape for hospitals. In terms of skilled nursing facilities, this comes from the Department of Health here. The darker the color, meaning more counties that have these skilled nursing facilities. So as of 2024, we had 666 of these facilities throughout the Commonwealth, but not surprisingly, there's a lack of these types of facilities within our rural communities across Pennsylvania. So the number of skilled nursing facilities, 223 in rural, over 400 in our urban areas. As we continue to age, and remember from our previous slides, the average age in rural is 2 years older than what it is in urban communities. There could be a greater demand for skilled nursing facilities. And to put a finer point on this, we've also mapped out the number of licensed beds for these skilled nursing facilities, and a similar phenomenon here. There's obviously a correlation between the facilities and the number of licensed beds, but in our most sparsely populated areas, in our rural communities, there's less access to these types of facilities and medical amenities. And obviously, this is going to pose a challenge for many individuals as they age in place or seek to age in place within their home county in Pennsylvania. And just for comparison purposes, we also broke out the number of healthcare facilities in rural and urban areas, and we standardized this. So it's an apples to apples comparison based upon 100,000 population. Now, it's interesting because in some cases, rural looks like it's doing all right. And not all of these measures, but in some of them, it looks like they're doing okay. But remember, we're just standardizing based upon population. And back to that map of rural and urban Pennsylvania, the county map, there's a lot of territory in Pennsylvania that's considered to be rural. So these measures don't necessarily take into account any sort of topographic considerations, natural barriers, drive times, things like that. I will get into some drive time issues here shortly, but just to put this in perspective, once we standardize by population, looks like there's more hospitals per population of 100,000 than there is in urban. But again, it's going to be really far spread out. A lot of this doesn't necessarily mean that it's accessible. There are more FQHCs and RHCs in rural than what there are urban. Skilled nursing facilities, looks like there's more once we standardize per population, but less retail pharmacies. Fewer physicians' offices, fewer dentist offices, and fewer substance abuse facilities as well. Now, if we look at providers, so instead of facilities, those who are part of the workforce, again, we're standardizing based upon 100,000 population. For primary care physicians, rural is less than urban, 58.1 physicians per every 100,000 in population compared to 86 in urban. Fewer pediatric physicians, fewer OBGYN physicians, much fewer psychiatrists, dentists, physician's assistants, nurse practitioners, and just ever so slightly more nurse midwives in rural than what there is in urban based upon that 100,000. So even though the facilities, again, in the previous slide, might have, once we standardize them, appear to be more in rural, whenever it comes to personnel, it clearly isn't that same phenomenon. It's different. And that's also one of the reasons why there are so many health professional shortage areas and primary care shortage areas throughout Pennsylvania. So the number of HPSA facilities in rural, 56 compared to 47 in urban. And here we map out, where there's correctional facilities, FQHCs, FQHC lookalikes, health clinics, and then any of the shaded areas are the primary care areas that are shortages throughout the Commonwealth. Now, I mentioned a little bit ago just the challenges of Pennsylvania's topography, and we're not taking into account things like drive times whenever we're standardizing this based upon population. And our data visualization specialist, Caitlin Good, was kind enough to put together this map of the Commonwealth. These are our hospitals throughout Pennsylvania. So the general acute care hospitals in yellow, and then we also included the UPMC Lock Haven outpatient emergency room in red. You can see that right here on the map. The dark green area surrounding each of these hospitals represents a 20-minute drive time. So this is based on actual road conditions surrounding all these different hospital facilities. So about 83% of Pennsylvania's population lives within a 20-minute drive to a general acute care hospital. 17% of the population does not. Now, you might think it doesn't sound like that's too bad, only 17%. Well, put that in context. That's 2.2 million people that are not within a 20-minute drive of the hospital. And obviously, the further out you get, the more precarious a medical situation could be. The next thing I wanted to highlight, and I think it directly relates back to our changing demographics, is our labor and delivery facilities. So here we have them mapped out. This is based upon Department of Health and U.S. Census Bureau data. You can see here any of the red crosses are those hospitals with labor and delivery. There's fewer of them now, and you can see the same 20-minute drive time mapped out. Now there's 28% of Pennsylvanians that do not live within a 20-minute drive time of one of these hospitals with L&D facilities. In other words, 3.6 million Pennsylvanians live outside of that 20-minute radius. And obviously that could matter a great deal. There there's only 3.4 million people in rural to begin with. But this is clearly even affecting individuals who live in urban counties as well. So 3.6 million Pennsylvanians outside of that 20-minute radius. And you can see there's just these huge gaps through the southern part, Pennsylvania, and through the central and northern tier. And I think this helps to better conceptualize the problem that we're seeing. We have another map that we didn't present here that takes into account labor and delivery options outside of Pennsylvania. So for example, in Milford here in Pike County, technically it would be shorter to go into New York. But obviously that could also cause some problems crossing state lines depending on, a patient's insurance, whether or not an EMT is able to transport someone there if need be. So for just the sake of this presentation, we were able to put together this map that looked at facilities within Pennsylvania itself. So if you're in any of these maternity deserts, you can see here we made it a sandy color for deserts. Sorry, we were trying to have at least a little fun with the color scheme. But hopefully that calls out where we have these 23 counties. You can see here throughout the south part of the central part of Pennsylvania, northern tier. These distances are from the county seat within each of these counties. So depending on where you are in the county, this is going to vary, but we figured, let's do the county seats because that usually tends to be a centrally located town within a county. And oftentimes it's the population center for the county. Not always, but oftentimes. And these distances are as the crow flies. It's a straight line. It does not take into account roads. It does not take into account topography or weather conditions if you need to get somewhere during the wintertime. And it just focuses on what is the next nearest labor and delivery facility within Pennsylvania. And you can see here in places like Emporium, for example. Actually, this is the longest distance. If you're in Emporium and you need to get to labor and delivery, as the crow flies, it's 52 miles to get to Du Bois. That's a heck of a distance for a lot of people. And there are many places here, Coudersport going to Wellsboro, 50 miles, Smethport going to Warren, 49 miles. There are consistently, distances of 20, 30 plus miles. And if you're on state routes, you may or may not be able to go at 60 miles an hour or 65 miles an hour. There are probably going to be lower speed limits to begin with. So for some of these areas, it is going to be more than an hour in terms of actual drive time, perhaps more to get to an L&D facility. So our concern here in presenting this information is the lack of L&D is going to exacerbate some of our population decline trends over time in our rural communities, because I think that there are going to be some individuals interested in moving into rural communities, but if there is a young family and they're looking to relocate, a lack of labor and delivery in a rural community may give them pause and may nudge them to look elsewhere to live and work. And similarly, we also have gaps in terms of pharmacies within our rural communities. And what we've plotted out here is a 5-mile radius, just to give you a sense of where these retail pharmacies are. And this is as of 2022. It's the last best database that we had access to from the Pennsylvania Department of State. And certainly there have been additional pharmacy closures over time. So this is probably a best case scenario for a lot of rural and even urban communities. What I think is interesting is if you look at pharmacy deserts, so those that are outside a 5-mile radius, that's basically more than 500,000 people in our rural communities. So more than a quarter of our rural residents are, outside this 5-mile radius. And even in our urban areas, you have over 150,000 individuals that fall into that situation. So we have hundreds of thousands of individuals who don't live in very close proximity to a commercial pharmacy. And tied again to our aging population, we just released a report within the last year with some researchers from Shippensburg University of Pennsylvania, looking at the demand for Alzheimer's disease and related disorders. This is what we're looking at here as of 2020. The estimated Alzheimer's disease cases, about 260,000, 68,000 in Pennsylvania, a little over 77,000 of those cases in rural, 191,000 of those cases in our urban areas. By 2040, they're estimating that we're going to be north of 400,000 of those diagnoses. And we're going to shoot up to 113,000 in rural and 288,000 in our urban communities. And I think many folks on the call recognize that not all communities have access to these types of facilities, and certainly the workforce may not be there, even if the facilities exist. So this is something I know that the Department of Aging is well aware of, and working with Department of Health and Human Services also to address over time. And related to our age and healthcare needs, I think it's helpful to understand what portion of our population is at least partially dependent on Medicaid and or Medicare for health insurance. And this is as of 2023. So about a third of the Commonwealth overall, just shy of that, we're at 30.6%, is at least partially dependent on Medicare and or Medicaid for their healthcare needs. If we break this out by rural and urban slightly lower, 29.9%, whereas in rural, we're slightly higher, 32.8%. But you can see some of these counties in rural Pennsylvania are beyond the 40% or threshold or coming very closely to it. Like Sullivan County here is inching towards 40%. Cameron County exceeds that. Obviously, Forest County exceeds that. Venango County is getting closer. Fayette County is already above that threshold. I'm sure everyone's aware of the implications of reimbursement rates relative to private insurance rates too. So this also places an additional strain on some of our healthcare systems and facilities. And related to that, what percentage of the population just doesn't have insurance in general? So about 5.6% of the population throughout the entire Commonwealth does not have insurance. It's a little lower in our urban communities and a little higher in our rural communities. And interestingly enough, some of the counties that don't have a high amount of insurance, Lancaster, Juniata, Mifflin, Snyder, again, also communities that have higher Anabaptist population too. So there may be some social and cultural reasons why some of those counties would have a higher rate relative to others. And I know that we passed along these slides, so I know I went through a lot in a very short amount of time, and sometimes it can be like drinking from the fire hose, but hopefully we can get into a conversation later, and you can also get a copy of these slides as a PDF, and we will go from there. And I see Professor Davis has her hand up, so I'll stop sharing my screen here for a moment.
Kyle, thank you so much. I always learn so much from you, even though I just saw this presentation less than a week ago, and I always learn more. But I do have a question for you. So in terms of looking at how the state ranks across the country in terms of live births, how do you see that changing in the next data collection process, given the reproductive regulations that we are seeing across all of the states?
That's a great question. I think that there's a lot of variables that influence, obviously, whether or not a given locale has a higher birth rate or a lower birth rate. And I don't want to just simply say, well, if we build more L&D facilities and staff them, that's going to make a difference. That is a consideration, certainly. And, we've had individuals anecdotally tell us that this has been a factor in their decision to start a family or expand their families as well, along with just general access to maternal care, women's health care, child care access. All these things are important considerations to it with our birth rates. Now, overall, the entire country more or less has been on this path to a lower birth rate for many, many years. So this isn't necessarily a new and recent phenomenon, but I expect this birth rate to more or less persist for the ensuing years. Now, even though we have lower birth rates, I think that as a matter of policy, we need to think about, do we want to have these deserts? Because if the deserts exist, I really think that's going to be a strong deterrent for young families moving to a given area. Particularly in the Northwest, that's an area that's approaching the size of Connecticut without a labor and delivery option to be found. That's very troubling for community planning, development, workforce, you name it, across the board. So we're going to have a pretty serious conversation about what this means for the future of some of these Pennsylvania communities. Sorry, I'm being really doom and gloom with this. I don't mean to be.
I want to ask the question, thank you for all of that. And I do want to ask it sort of another way. In terms of looking at the Supreme Court's decision to overturn Roe v. Wade, and the changes that states have made, or states like Pennsylvania have not made, how do you see us then being able, how do you see us on the scale in terms of our live births versus other states that might be a bit more restrictive?
Oh, okay, I see. I don't have great data on this right now. We actually had a legislative request about this maybe a year ago. And we did our best to come up with a calculation on what it would look like if Pennsylvania had more restrictive abortion laws on the books. It's conceivable that that would make a difference on an annual basis. I'm trying to remember the exact number, but it was over decades. It would have resulted in maybe another 100,000 more births over, I want to say, a 20 to 30-year time frame. So I'll just leave it at that. There's a lot of assumptions that went into it. Is essentially a back of the envelope calculation that we came up with. I haven't seen hard data yet, or we haven't calculated like how does Pennsylvania compare to Ohio or Louisiana or Florida or Texas or anything like that. Presumably they do have a little bit higher birth rate, and we have seen that some of the more restrictive states are still there above Pennsylvania on average. But even with that, no state is still at that 2.1 threshold.
Thank you so much.
Other questions?
Oh, sorry, I was muted. In the interest of time, I think we'll let Lisa start her side of the talk, and then maybe leave this some time towards the end for the discussion. Is that be okay?
Yep, that sounds good to me. I'll turn it over to Lisa then.
Thank you. I had to ask Kyle now because by the end of the presentation, I will have forgotten. So speaking of the golden tsunami or the silver tsunami. So I'm really delighted to be able to talk to you all, and thanks again for having us here. And I do want to say Kyle and I think, have created a nice complement of presentations. He is very data driven, which is exactly what the Center for Rural Pennsylvania should be. And we rely on all of those data for the work that we do. And then I'm coming in with a little bit more of a social perspective on it rather than the hardcore data perspective. So what I'd like to talk about is, more need. And so now what? And just really quickly, for those of you who may not have been on previously or forgotten who we are and what we do, we are the State Office of Rural Health for Pennsylvania. So there's an office like ours in every state in the nation. We're one of 10 that are university-based. All of the rest are in health departments, except for a couple that are 501c3s. And we are funded through a federal-state partnership from the Federal Office of Rural Health Policy in HRSA, and also from the Commonwealth of Pennsylvania, where we get match funding from our Pennsylvania Department of Health, and we also have a large Ag Safety and Health grant that is funded through the Department of Agriculture. And we're located at the Penn State University Park. And our role is, our mandates are to provide technical assistance, information dissemination, coordination, partnership development, and so on. But each state office is designed to serve the individual needs of their state. And so we focus on a broad range of issues, including policy, population health, quality improvement at our facilities, a focus on vulnerable populations, oral health, you name it. Really, our job is to understand at an in-depth level, at the local, state, and national levels, all of the policy, legislation, regulation, funding, best practices, worst practices, who's doing what, how they're doing it, how they could, should, might be doing it, and package all of that up so that we can provide the best technical assistance to the state's small rural hospitals, to the federally qualified health centers in rural communities, and also to our 70 rural health clinics, as well as all of the clinical training programs across the state, community-based organizations, and so on. So I was putting together some slides about essentially what the silver tsunami is going to mean in terms of aging out of the workforce. And when Kyle and I put together the abstract and description of what this presentation was going to be, we had not anticipated, I think, that we would be looking at so many changes at the federal level. And as I was going through and reviewing what the silver tsunami change in the workforce may look like, I think it reflects very much what we are seeing now, where we are seeing that as workers are leaving positions, that we are losing institutional knowledge, and potentially losing some productivity, that as we begin to fill those positions with a younger workforce, we've certainly seen this when we're talking about clinical training programs, we see an increased demand for flexible work arrangements, part-time jobs, and so on. We are also seeing and will be seeing that aging populations obviously require more healthcare services. There will be an increased demand for providers, caregivers, and so on. We will be looking at additional strains on the Medicare and Medicaid programs, also on Social Security. Now, I've heard a number of different reports on, let's say, for instance, National Public Radio, saying that we may or may not be seeing changes in Social Security. I think that if we did see any changes, all of us who are above 65 would be contacting our legislators pretty quickly. But it doesn't, what it means though, is that we will have a smaller number of individuals in the workforce who are supporting through taxes a larger number of individuals on Medicare and Medicaid. And we also will begin to see a significant boom in the demand for assisted living facilities and medical innovations and so on. I think actually in some rural communities, retirement communities are some of the fastest growing workforce and components of the economic development structure in rural communities. We're also going to see a change in consumer spending. So those who are retired may in fact be changing how they are spending their discretionary funds, if they have any. So they may not buy as many cars, they may not go on vacations, they might be downsizing. So they're selling their large home and they are moving into either a retirement community or a much smaller apartment. And so in selling these homes, we are looking at having potentially an increase in housing supply in some areas. And actually, I've heard that that is the case right now in the Washington, D.C., Maryland, and Virginia area, where those who are leaving federal employment are trying to sell their houses, which of course really, I think, causes changes in buying and selling habits and prices in those communities. We're going to see again a higher demand for retirement planning and estate management. I did see a commercial yesterday enticing individuals to go into law and to practice estate management. They were saying it's a delightful profession, and you don't have to go to court, and you usually are making people happy. Again, Social Security challenges, where we will be looking to a growing number of retirees relying on perhaps a smaller amount of funding, and the same for pension and healthcare costs. And then on the other hand, the growth of the silver economy. So we may, in fact, and I think we are already seeing this, is industries that are springing up that are catering to seniors, such as health tech programs and robotics and smartphones and smart homes and elderly friendly products. We may see an expansion in that, although I know that for, say, for instance, telehealth, what we have seen is that seniors perhaps would like to use telehealth, but they're not quite sure how to do that because many of them were not raised using a computer, or they rely on their children or grandchildren for helping them do that. So I'm going to shift now and talk a little bit about what's happening across the country with nursing home staffing requirements and what that means in states like Pennsylvania. In April of last year, the Centers for Medicare and Medicaid Services finalized a rule that required nursing homes to increase their staffing ratios so that it met a minimum standard of 3.48 total nurse staffing hours per resident per day. And what that means is that looking at registered nurses, that increased to 0.55, nurse aides 2.45, and that is higher because they are the ones who are providing the most care to those who are in nursing homes, and that there must be an RN on site 24/7. And I think in many nursing homes, they were having RNs on during the hours when there was the most activity, but then not having an RN on staff from the 11 to 7 a.m. shift. And that facilities are required to conduct and document a facility-wide assessment to determine resources that are necessary to care for residents. Facilities also can apply for a hardship exemption if they find that they are not able to meet these minimum staffing requirements. So I think that there is a yin and a yang to this. One is that for any of us, whether or not you have someone who's been in a nursing home or you've worked in a nursing home, there is no denying that nursing home work, working in a skilled nursing facility is hard work, and that the residents who are in these nursing homes deserve the absolute best care that can be provided. So that is one side of the equation. The other side of the equation is that Medicaid is one of the highest payers of nursing home care across the country. And that reimbursement for services tends to be lower than what it actually costs to provide the care, so that nursing homes are very often operating in the red all the time. And those that are affiliated with a hospital are very often supported by the hospital. And we've seen here in Pennsylvania that several nursing homes have closed because it is so difficult to keep them open. So while we have both the need and an intense need that is completely legitimate, on the other side, we also have restrictions in terms of how much nursing homes are reimbursed for the services that they provide, and also how challenging it is to be able to fill those positions. RNs, we seem to have not as hard a time attracting and retaining RNs. The nurse aide staffing, though, is constantly changing. It is very hard work for low pay, and we see not only challenges in recruiting, but especially challenges in retention. So Pennsylvania revised its nursing home staffing regulations to comply, and they increased the numbers of direct hours to 3.2 hours per day per patient. And that was effective July 2024. And so in fiscal year 2025, we're seeing an increase in payments by 2% or about 45 million. And this includes a 3% market basket update and other kinds of assessments that go into this. Here in Pennsylvania, we have 669 nursing homes as of August of last year. So reduce that number. I think we now have 667. We had 695 in 2019. So if you look at the maps that Kyle presented, you can see that while we are decreasing the number of nursing homes, assuming that this projection continues through 2050, we are going to need a lot more nursing homes and a lot more nursing home beds in the state. The state's skilled nursing facilities care for about 80,000 individuals. That certainly is going to increase. Medicaid, medical assistance in our state, pays for nearly 2 out of every 3 skilled nursing facilities, residents in these nursing facilities. And there are closures concerns. The Pennsylvania Healthcare Association, which represents not-for-profit nursing homes, warns that more nursing homes could close or declare bankruptcy. And this is because of a history of underfunding. We're looking at inflation. We have the staffing mandates now, a higher reliance on Medicaid programs, and the fact that we now have a demand for a workforce that we may not be able to fill. So what is Pennsylvania's investment in long-term care? In the current budget that we are in right now in the state, about $120 million annually goes to the Medicaid program for nursing home residents, and that is effective January 1st, 2025. I don't know if any of you have ever looked at any of the spreadsheets that come out from the Department of Human Services, which runs the Medicaid program. Every month, they revise how they are paying nursing homes, depending upon a number of measures that they bring in. And of course, they're supporting the nursing home staffing mandate. They also added $5 million more to something called the Medicaid Day One Incentive, which is for facilities that serve high Medicaid populations. But just as Kyle was showing, and I think this is from the same report that he was referencing, the state could have 133 more Alzheimer's patients by 2040, and the support system is facing significant challenges. In the 2025 budget, the Department of Human Services is requesting $21 billion. 27 million of that is for long-term living, and there's also 20 million to increase the Penn Care program, which is funding that's provided to the area agencies on aging. And all of our counties have an area agency on aging, although a few of them serve 2 counties. But the big question is, what happens if Medicaid is cut at the federal level by $800 billion? And I don't know if any of you had an opportunity to watch the budget hearings, especially for health and for the Department of Human Services. Both secretaries were asked this very specifically, and especially Secretary Arkush from DHS. She was asked, what will you do? How is the state going to address this? What are we going to be seeing in the state in terms of reductions or changes in our Medicaid program? And the answer, of course, is they are preparing, but they don't really know what to prepare for because we don't know how this is going to move forward. So it is a very uncertain time. And we have a Pennsylvania Department of Aging, and Medicare pays for the first 100 days after hospital discharge. That's not observation. And many families don't realize that. If an older person is discharged from the hospital, but they were there for observation only and not actually admitted to the hospital, Medicare will not pay. So about 20% of the state's nursing homes are not-for-profit, and Medicaid pays about $9,200 a month. But in for-profit nursing facilities, if you are looking at paying out of pocket for a private room in a for-profit skilled care unit, that is about $11,000 a year, about a month. And coming from a family that paid that amount, we actually paid much less than that. This was about 20 years ago. We paid $6,000 to $8,000 a month. It is difficult to be able to afford that over a long time. And then the state also has a waiver for something called Community Health Choices, which provides in-home long-term care services to families that qualify. And then we have a Department of Aging, which provides funding for adult day services, long-term care, ombudsman, financial services to provide for financial exploitation. They have housing programs. They run the PACE and PACE-NET programs. And they also fund the area agencies on aging. And just in the last month, the Department of Aging has announced a new focus on accountability to those area agencies on aging for addressing elder abuse claims. There was really no way that the state had to track those claims. And so now they have put in, I think, what will turn out to be a very robust system for doing that. The Department of Aging also published their 10-year strategic plan to focus on the infrastructure for the next 10 years in terms of how we are going to address serving the elderly across the state. And I think there are really two ways to be able to do this. One is being able to have a very good system of long-term care facilities, whether it's personal care or a skilled nursing facility across the state, or to be able to find ways to coordinate care so that individuals can stay in their homes. And I think as this generation that is just beginning to become 65, and don't forget 10,000 people a day in the United States turn 65, we are going to see changes in the demand for the way in which services are cared for. Many of us have seen our older relatives in nursing facilities, and we have all said, please do not let me be like that. So we are going to be seeing, I think, a high demand for change across the state and across the nation for how older persons are cared for. And I'll end on talking about caregivers. They are really the unsung heroes of older person support. And, it is physically and emotionally exhausting to care for someone. If any of you have cared for an older person in your home, or someone who lives in your neighborhood, or a family member who lives close by, having that thought always in your head about, what do I need to do? What's going to happen next? What will they need? Can I get them out and about? Am I living with them? And so are we now fairly socially isolated? And so there have been a number of studies that have looked at the economic and physical and emotional impact on caregiver health because of this strain that they are under. And it is both financial, physical, and I think it's such a personal sacrifice for individuals who are caring for older persons. And the other is they have to navigate the healthcare system. And for those of us who work in healthcare, this is challenging enough. What if you have never had to deal with that and you are now starting to figure out how healthcare works. You are now the only person who may be making decisions. You have to become essentially an RN because you have to understand how medication works, and what should be taken with what, and what the co-indicators might be between medications. And then also dealing with cognitive decline, which goes toward the elderly who are going to be experiencing dementia. So here is my contact information. Please feel free to contact us. Just so you know, the Center for Rural Pennsylvania and the Pennsylvania Office of Rural Health work very, very closely together. And so if you reach out to one of us, chances are you'll be able to get both of us. So thanks very much. And I left us a whopping 3 minutes.
Excellent timing. Thank you, Lisa. Any questions for either of our speakers, I guess?
I see something in the chat.
Oh,
Oh,
that's Kyle offering for help.
Well, I have a very quick question. Like, I hear like Lisa mentioned like robotic use for the elderly care. Did people look at like, is there a difference between the rural and the urban, or like related?
Oh, you mean in terms of being able to offer those kinds of sort of high-tech services?
Mhm.
You know, I don't have a specific answer for that, but my guess would be, I know that the small rural hospitals that we work with are struggling so much financially that to be able to afford something like a robotics kind of, or, you know, it can be really challenging. And those are available specifically if a small rural hospital, it merges with a large hospital, a large health system. However, I did just see a presentation from WellSpan, and they are looking into purchasing a robotic kitchen process where a robot can be programmed to make one of, let's say, 30 different meals. They load the recipes in, they load the ingredients in, and that robot can make up to 50 meals in 5 minutes or something that's remarkable.
Wow.
So I think that, you know, while there's a significant upfront cost, you know, it may find that you save money in the long term.
Mhm. Thank you.
Well, we have 30 seconds left. Just so you know, I reorganized my slides a little bit, so I'll send you a revised version.
All right, thank you. Any other questions for our speakers?
Thanks for having us.
Thank you for always sharing your thoughts.
Great talk.
Yeah. It's
Kyle's
all
the popular one.
I don't know about that.
I think next year, not to speak for Kyle, but it might be really interesting to see what the Rural Population Revitalization Commission develops over this year. You know, even if it were just some introductory activities.
Yeah.
All right,
Not
sounds
to put you on the spot, Kyle. All right. Bye,
All right.
everyone. Have a great rest of the Monday.
Yeah.
Bye.
Thank you, Lisa. Thank you, Kyle. Bye.
Bye-bye.